This is a case of endovascular management for a critical middle cerebral artery symptomatic restenosis that presents with neuro-occlusion from intracranial atherosclerotic disease. Patient is a 76-year-old male who's presented with dysarthria and progressive left arm and leg weakness over the last 4 days, had left hemiparesis with homonymous hemianopsia, has prior history of diabetes, hypertension, and MCA stenosis, for which he went submaximal angioplasty 6 months prior on aspirin, Plavix, and insulin. Non-invasive imaging, including MRAs, suggests a critical M1 stenosis, which is recurrent. Diagnostic angiogram shows worsening of that with very little flow going across the long segment atherosclerotic disease. This is crossed through an 014 microcatheter system. You can see a 6-French guide in the petrous carotid, and then a submaximal balloon is brought across the segment. This is the 1.5 millimeter balloon, and very slow progressive angioplasty is performed. Our routine is to go up 1 atmosphere every 30 seconds, and deflation is very slow too, coming down 1 atmosphere every 15 seconds. This allows for gradual inflation and deflation. At this point, we believe we have good restoration of flow. You can see flow alongside the balloon, and then repeat angiogram suggests recurrent collapse. So while we still have our wire across, we elect at this point to bring a wingspan stent. You can see the wingspan stenting system across. The distal marker is the distal marker of the microcatheter. The next 2 markers are the proximal and distal ends of the wingspan stent. They are pushed forward till we start seeing expansion of the distal tines, and the device is then delivered essentially by keeping forward pressure as we unsheath the stent in place. There you can see the stent has nicely opened up proximally, distally, although it remains relatively small. At this point, we then pull the delivery system back out, leaving the wire in place. You can see there's some more opening of the distal stent as well, and we do an angiogram, and at this point we see good flow through the long M1 stenosis. This is the final run, suggesting some narrowing still distal to the previously placed stent. We proceed with a Dyna CT, which shows good placement across the whole length of the M1. This is an MCA trifurcation, and there's some narrowing distal to the distal tines of the stent. We believe this may be related to vasospasm, and verapamil is administered with patency of the stent extending all the way to the ICA terminus.